All right. After that nice deep breath, let's talk about lung volumes and some basic applications of basically different lung volumes and how they relate to some basic clinical testing and also how they relate to certain types of diseases. Again, this will just be more of a general overview because remember, this is for undergrad A&P students. So basically, what we're going to talk about is we'll talk about the lung volumes, and then I'll just wind up integrating lung capacities in there with that. And then I'll just talk briefly about the concept of dead air and different types of ventilation rates. Because realistically, what this is going to be all about when we talk about lung volumes and lung capacities, we're essentially, I mean, in previous videos, I talked about the mechanics behind ventilation, how we essentially get air into and out of the lungs for the purpose of gas exchange, and what this topic is going to be about are the volumes of air that we're actually bringing in and getting rid of. Like I said, for the purpose of getting oxygen and getting rid of CO2, and anything that essentially compromises the mechanical aspects of breathing is essentially going to compromise the normal values that are associated with ventilation. And basically, we're going to have abnormal lung volumes and lung capacities. All right, and the two very common types of lung disorders that you think about are restrictive and obstructive disorders. And whereas restrictive disorders are basically a loss of compliance of the lungs. Or when I say loss of compliance, basically the lungs are less elastic or less rubbery. They get more stiff, which you see with fibrosis or scarring of the lungs. Like with most common clinical example of that is going to be pneumonia, chronic bouts of pneumonia where someone gets pneumonia a lot. Tuberculosis is an extreme example of that. Whereas people can also have what are called obstructive disorders, and with those obstructive disorders, that's different because the compliance of the lungs isn't really affected. I mean, it's affected a little bit. Don't get me wrong, but not nearly as affected as like with a black lung, coal miner's lung, where where you're underground, where you're a mile underground, breathing in pure carbon, and so much of that builds up in your lungs. Your lungs are rock hard, not like literally like a rock, but they're really stiff. And whereas with obstructive disorders, this essentially is where the airways, especially the bronchioles, are obstructed. They're more narrow. They collapse. They're filled with mucus. There's inflammation, like with asthma or other conditions. And and those types of disorders affect the volume of air going in or out because the actual lumens of the bronchioles are narrower or obstructed. That's why they're called obstructive disorders. So, regardless if a person has a restrictive or an obstructive disorder, these lung volumes and lung capacities are going to be affected by that, and you can essentially measure that by doing pulmonary function tests. And when you perform pulmonary function tests, you use a tool called a spirometer. Okay, a spirometer. A spirometer basically is is essentially a breathing tube that's hooked up to basically water or some kind of gas in it, and then basically you breathe certain ways into that, and then basically the gases are displaced, and the fluids, or there might be a ball in there or something, move up and down, and then you can basically test. Um, you can gather a lot of information about the functionality of the lungs. This day and age, everything is computerized, and I mean, I remember the first time I really did this. It was with a computer. I was an undergraduate student. I was about to do my VO2 max test, which is the volume of oxygen consumed during exercise, essentially the maximum amount you can consume. And prior to doing that, I remember, and afterwards, that was not fun. Basically using the computer to breathe in and out of and collect these values. So but basically a spirometer is a tool that you can do this with. So basically, there's a couple of factors that we have to think about then when we're thinking about the process of ventilation and essentially the volumes of ventilation. Remember, in previous discussions, we talked about the physical properties of the lungs, which I actually kind of discussed um, in the previous slide, where I said lungs can become more stiff, like with restrictive disorders, and or if there's not enough surfactant in premature babies. or if there's something that's causing bronchoconstriction or dilation, that's going to affect the physical properties of airflow into and out of the lungs. All right, and then the other critical factor here that when we're dealing with ventilation are basically muscles. All right, your respiratory muscles, and remember the main muscle, the prime mover of the breathing process, is the diaphragm. All right, and then other muscles can be affected by this as well. And one thing to keep in mind about this when you're thinking about respiratory muscles, remember that whether you're talking about the diaphragm, the scalenes, the sternocleidomastoid, the pec minor, internal, external, intercostal muscles, the abdominal muscles that are involved in inspiration and expiration, whether it's quiet or forced, those are all skeletal muscles. So we exert voluntary control over those, right? And remember, one of the characteristics, one of the basic fundamental characteristics of skeletal muscle is that the harder you work it, the stronger it's essentially going to become, and that goes with and that goes with exercise. That's why people's lung volumes and capacities tend to go up the more they work out, because they're forcing themselves to breathe harder for longer periods of time. You're going to slightly strengthen those muscles. All right, and vice versa. That's why sedentary people are going to have lower capacities, or in more extreme cases, people who are in comas or who just came out of a coma, people who are they're confined to a wheelchair, or bedridden people who don't move around a lot. All right, they're gonna. That's one of that's one of the contributing factors to lowering these volumes, disrupting the mechanical process of breathing by having weaker respiratory muscles. All right. So that's kind of something to keep in mind. So those are a couple of things you should keep in mind. And then again, I'll come back to these when I talk about kind of the disease process related to this as well. So basically with the spirometer, we can collect various volumes of air that we're breathing in and breathing out, right? And remember when you're thinking about breathing, remember one breath or one cycle of breathing. Okay, one cycle of breathing consists of two phases, right? And you know this is simple. It's inhaling, and you know the opposite of inhaling, exhaling. Okay, when you take a breath in and then blow that air back out, that is essentially one complete breath. Okay, or we've completed the breathing cycle. And now probably even before you taking anatomy or even getting into this topic, that we don't necessarily breathe in. We don't when we're at rest, when we're quietly breathing, we obviously are not utilizing the entire volume of our lungs. We're only expending enough energy to basically take in the volume of air that we need. And you know that we can adjust our ventilation rates, and so we can increase respiration based on our metabolic needs. All right. When you're quietly breathing, when you're at rest, there isn't a great need to bring in a lot of air because you're not producing a lot of carbon dioxide as waste, and you're just not burning as much oxygen. So these values are going to be lower at rest. Whereas vice versa, when you're breathing harder, you're utilizing secondary muscles of breathing, ventilation. These volumes are all going to increase. All right. Well, not all of them necessarily, but you get the picture there. Now, tidal volume. Typically used with capital T subscript V, tidal volume is the volume of air that you take in per breath. Okay, so every time you take a breath, in, and remember, one breathing cycle essentially is your tidal volume. Air in, air out. All right, and I've said this before in other videos, and I said this before in lectures in my class, that the average volume of air that a person at rest breathes in and out is about 500 milliliters per breath. Okay, 500 mils per breath, which would obviously equal 0.5 liters. Okay, so basically what I'm saying here is that with every breath, we're taking in half a liter of air with every breath. All right, that's all we need to take in to essentially keep ourselves alive, because remember, those factors that increase the physiologic functions or make the lung such an efficient physiologic machine. You're spreading air out over a large surface area. The respiratory membranes where gas exchange occurs are incredibly thin, simple squamous epithelial tissue. What else was I going to say? The close proximity of alveolar air sacs to pulmonary capillaries, so gases don't have to travel very far for gas exchange. All right, so basically, we don't need to breathe in a lot. That's enough, essentially, to keep us alive when we're at rest. All right. Now, you know that when a person is basically that when a person is exercising, you know what's going to happen to tidal volume. Tidal volume is going to go up. All right, you're going to mechanically breathe in more air. So you might go from breathing, I don't know, you could go from breathing, let's say, depending on how intensely you're exercising, you could go from breathing in half a liter to air to 2.5 liters, 2,500 milliliters. All right, again, it just depends on how hard you're working, how good a shape you're in. There's a lot of factors that influence that. But in general, when you are physically exerting yourself, like an exercise, or there's anxiety, or you're stressed out, driving through the state of Minnesota, whatever it may be, where something is stressing you out, your tidal volume is going to rise. Okay, but it's going to rise proportionally to meet those stressful demands. All right, now let's think about this then. When you're using a spirometer to measure people's volumes, now remember, there's a mouthpiece involved in this. Now remember, whenever you are doing spirometry tests on somebody, you always put a nose clamp on their nose so you don't have any air escaping the nose. So basically, you're only funneling air through that tube so you can collect that data, so you can collect as much air as possible. All right, and so think about this for a second. If you wanted to measure somebody's tidal volume, what would you instruct that person? What instructions would you give that person if you wanted to assess their tidal volume? This is simple. All you do is you just tell them to sit there and breathe. You just say, sit there and breathe. All right, so then they sit there and breathe, and then and now remember though, when you're doing this on a person, especially on like an average or healthy or semi-healthy individual, make sure that person is sitting upright, or standing upright, or whatever. Make sure that their torso is upright. Remember, folks, I studied biology, not art. Now, there's a reason for that, because even do this while you're listening to this. Lean forward and try to take in a deep breath. Try to pull in as big of a breath as you can, and then sit up straight, and then try pulling in a big breath. You notice when you hunch forward, it's a lot more difficult, right? Because when you flex your torso, all right, and you compress your abdominal contents up against your diaphragm, you make it, you alter the mechanical properties of the diaphragm and basically make it more difficult for the diaphragm to flatten out and increase the dimensions of your thorax, thus bringing more air in. So if a person is slouched forward when you're collecting these values, especially something like tidal volume, you could screw up the numbers essentially. Okay, so tidal volume is just how much air a person takes in per breath. That's it. It's simple. Now, as I mentioned before, we are not utilizing the entirety of our lung capacity when we're breathing in. Excuse me. So basically, there's a certain volume of air that we can inhale into our lungs beyond tidal volume, and that is what inspiratory reserve volume is. Okay, that's what inspiratory reserve volume is. How much air you can breathe in, how much air you can fill your lungs up with beyond tidal volume. That's the key thing there, is beyond tidal volume. Okay, so that's all inspiratory reserve is. And the average volume for inspiratory reserve is 3.1 liters, or 3,100 mLs. Okay. Now again, these are numbers that I'm throwing at you. Like I said, if you might be using a different book. All right, these numbers are going to be kind of around these general ranges that I'm giving you, so that's something to kind of keep in mind. All right, but basically that's inspiratory reserve. So what we're saying here is that the average person, especially like these numbers are typically geared towards like your average kind of like I don't know, like your average height male, about 70 kilos and so on, average weight male. Now these are going to fluctuate a little bit here and there. Like if you're a little woman, these values are going to be smaller. If you're Shaquille O'Neal, these values are going to be bigger just because Shaq's a large American. All right, so that's something to keep in mind. So think about this then. How would you test a person's inspiratory reserve volume? What instructions would you give that person? This one's easy. Basically, you would so like I said, this is the amount of air you can breathe in beyond tidal volume, right? So what you're gonna do is you're gonna tell that person is you know what you mean typically like what I've done in the past is you have the person put the mouthpiece in, and then you usually let them give them instructions before they put the mouthpiece in obviously but or even while they do it, but then you just let the person sit there and just take a couple of breaths, count like 3, 4, maybe 5 breaths depending on it's subjective depending on you, and then you tell that person to just bring in as much air as possible. Fill their lungs up with as much air as they possibly can. Just inhale, 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 inhale. Just keep pulling in air until they can't pull in air anymore. Obviously, they're doing this with with their mouth and the mouthpiece, but again, you're gonna get a value with this, and like I said, if you're doing it with the kind of the gas and water, the old school spirometer, as those gases and fluids are displaced, there's a needle that's connected to that's collecting these values on on a graph, kind of like looks kind of like a lie detector test almost. But we'll see the graph in a little bit, but that's kind of how that works. All right, it's not like a lie detector test, but you get the picture. So that's essentially how you would collect inspiratory reserve. Now, so then obviously if we're only taking in half a liter of air per breath, and there's a certain volume of air we can bring in beyond tidal volume, logic would dictate that there's a certain volume of air we can exhale beyond tidal volume as well. And that's what expiratory reserve is. Okay? And basically the average value for expiratory reserve is 1.2 liters or 1,200 milliliters. Okay. Now, that probably made you take pause there for a second because basic logic would dictate if the average value of inspiratory reserve that we can bring in beyond tidal volume is 3.1 liters, you naturally want to think, okay, well, the volume we can bring in should match the volume that we're blowing out. Right. However, that's not this case. It doesn't work like this, and I'll explain that in a second. But again, when you're trying to measure somebody's expiratory reserve, it's an easy it's the exact opposite of inspiratory reserve. Have them again put the mouthpiece in, make sure the nose clips on. They take a couple of breaths, and then you just tell that person to blow out until they're blue in the face. Completely empty their lungs out. Now, this, in my opinion, is the most uncomfortable one out of them all, just because it's a bizarre feeling to blow that air out, to try to deflate your lungs as much as possible, especially if you're working with a computer, like a more advanced spirometer, because typically, obviously before you do these tests, you're always going to enter in a patient or, if it's research, the information about that person and the research subject, you pinhead. So basically, you're going to enter in the information about that patient or subject, like gender, height, weight, age, all that stuff. The computer will kind of calculate a rough shot estimate about what these values should be. And when you're doing something like expiratory reserve, and I remember doing this myself, on myself with other people obviously around, but I remember blowing out, just blowing out, and the computer just kept saying, keep going, keep going, keep going. It is a weird feeling to just keep blowing air out when you think you just can't possibly blow any more air out. But basically that's how the test works, and then eventually you just keep blowing and blowing and blowing, and like I said, until you just can't empty anymore, and then eventually you're going to reach a certain point. But like I said, that's going to be that's going to be less than half of the inspiratory reserve, and there's a reason for that, and that is because of residual volume. Okay, that's because of residual volume. Residual, basically left over or remaining. All right, now what residual volume is, it's the volume of air that is left in the alveoli. So there's always a little bit of air that remains in the alveoli at all times. Okay, now this is really, really important because remember, there is a lot of connective tissue inside of the lungs. All right, there's a lot of connective tissue around the alveolar air sacs that the basement membranes of them, and then the basement membranes of the pulmonary capillaries. There's a lot of elastic fibers. There's just a lot of basically there's a lot of sticky stuff in the parenchyma, or the internal kind of skeleton of the lungs themselves. So if we were to completely empty our lungs and our lungs fully collapsed, Well, what would happen are all those tissues would collapse on themselves. These alveolar air sacs would collapse on themselves. Pulmonary capillaries would start to, collapse in there as well. And basically, what would happen are all the basically the all this gluey tissue would start to stick everything together, especially the alveolar air sacs. Now, picture this: you completely collapse a lung. You have these alveolar air sacs collapse in on one another because remember, alveolar air sacs, they're like grapes, right? So you've got so basically you've got a bronchiole, then you've got the terminal bronchioles, and then you've got a bunch of alveolar air sacs kind of stuck together. Okay, so then picture all those air sacs kind of collapsing on one another and sticking together. Now, what do you think is going to happen if you were to forcefully move air right back into the lungs and forcefully bring air into all those alveoli that are glued together? You're going to tear them to shreds. You're going to tear them apart. And that's going to basically what you're going to do is you're going to damage the physiologic areas of the lungs. You're going to damage the respiratory zones where gas exchange occurs. And then that's obviously going to bring your lung capacity down, and that's, well, bad news. That's why when a person has, for example, pneumothorax and a lung collapses, i.e. atelectasis, um, when a lung collapses, that's why you don't refill the lungs with air. You figure out, remember, you repat, if there's some kind of traumatic injury to where the thoracic cave, where the pleural membrane got torn, someone got shot, stabbed, car accident, whatever it may be, and they're bleeding into that, bleeding into that pleural cavity around the lung. You suction the fluids out, reseal the pleural membranes, reestablish that pressure gradient between the inside of the thorax and the atmospheric air, and then basically once those pressures are reestablished, then just over the duration of a couple of weeks, as that person just continuously breathes and kind of and slow, and that air will slowly rebuild up in that lung. The lungs will slowly reinflate themselves, and then all will be well. And that's the importance of residual volume to keep the lungs from collapsing. All right, because there's basically we have these built-in reflex mechanisms to prevent the lungs from overexpanding and from collapsing. They're called the Herring-Brewer reflexes. There's an inflation and a deflation reflex. Right, when we inflate our lungs too much, like for example during exercise, our lungs are going to stretch out beyond what they're normally beyond their normal resting limits, and that essentially is going to once the lungs inflate so much, there's an inherent reflex that stimulates you to stop inhaling and start exhaling and empty out your lungs. And then vice versa, when you deflate the lungs, when you're releasing air out of them, again, similar reflex, except it's triggered by deflation. When they deflate so much, that's going to trigger an inhalation so you can bring air back in. All right, so that's the point of residual volume, and that's why expiratory reserve volume is always going to be lower than inspiratory reserve. All right, and now you cannot measure residual volume with spirometry. All right, you can't do that. I mean, there's certain like specialized gas tests that you can that you can use to possibly measure this, estimate it, but for the most part, we like to say that residual volume in the average person is about 1,200 milliliters. Okay, or 1.2 liters. Okay, 1.2 liters. That's essentially residual volume. So now when you take this and add it all up, all right, when you take this and add it all up, basically when you add all these numbers up, you essentially get 6,000 milliliters or 6 liters. So a person with these values would have a total lung capacity, a TLC, of 6 liters. Okay, and that's essentially how we utilize these volumes with our lungs. Like I said, all right. So now let's take a look at this actually graphed out here. I'm actually going to explain these capacities on this one. So basically, there's a certain set of capacities that we can also assess by basically. Now the thing with capacities is that you get capacities by adding volumes. Okay, which I have the basic formulas right here. There's basically a total inspiratory capacity, basically the total amount of air a person is capable of breathing in. And basically all you would do is take tidal volume, add it to inspiratory reserve, that's inspiratory capacity. I made a whoops, because that was supposed to be functional residual. Oops, sorry about that. That's supposed to be functional residual capacity. So basically, that's just, basically when you add these two values up, that you're essentially getting the full amount of air. Um, Basically, that's in the lungs after, normal, after breathing. Vital capacity is a big one. Vital capacity is a big one, because basically what's going on with vital capacity, that's basically what you're looking at. You're looking at the maximum values for gas exchange. So vital capacity, look at what's added up here. Inspiratory reserve plus expiratory reserve plus tidal volume. So basically what you're doing is you're adding up all of the values. You're adding up them, and basically what you're doing is you're getting the maximum amount of what you can get out of one full breathing cycle. So the maximum amount of air you can breathe in and the maximum amount of air you can exhale. And then again, when you slap all this together, you get total lung capacity. Okay. So I'll explain those more on this. So let's kind of take a look at this here. So basically over here, basically we've got volume. Okay. This would essentially be volume. Now, take a look at this right here. So when you see, so basically when a person takes a breath in, when they're hooked up to a spirometer, when a person takes a breath in, you're gonna see an upswing on the graph. If it's computerized, the line's just gonna go up. If you're actually using a needle and paper, the needle's gonna draw the line up. So then, what do you think is happening then when you see a downstroke? You're breathing out. That's exhaling, right? That's exhaling. All right. So basically, what you're looking at right here, this is one breathing cycle or one breath. Okay, that's one breath. Okay. Now, essentially, what these lines are, what this one breath is essentially showing you, this is tidal volume. Okay, that's tidal volume. Now let's think about this for a second. For starters, how come we're starting? We're starting at a little over, basically, at a little over 3 liters. Why is that? How come we're not starting at 0? Remember, residual volume. Okay, there's always a certain volume of air that's always left in the lungs at all times to prevent deflation, right? To prevent complete deflation. So that's why, so that's why essentially tidal volume is so high up here, numerically, on the graph. So basically, and remember that when we're breathing quietly, when we're breathing at rest, all right, we're only breathing in half a liter of air on average per breath. So that's why these are so small. Okay, and you know that there are certain volumes beyond tidal volume that we can inhale gases at. So basically, you can figure out then why this would represent inspiratory reserve. Okay, when that person takes that maximum breath in, okay, that's essentially inspiratory reserve, and then you can then see why this would be expiratory reserve. Okay, expiratory reserve. Because this person is, this is how much air that you're trying to blow out. Now remember, why expiratory reserve is always going to be smaller, because of residual volume. We do not completely empty our lungs. Okay, we do not completely empty our lungs. And then when you take tidal volume and add it together, all right, when you add the two together, excuse me, that's basically when you get inspiratory capacity. Okay. That essentially is inspiratory capacity. So basically right here is inspiratory capacity. I'm just going to abbreviate that. Okay. And remember that the average tidal volume is 500 milliliters. And then the average inspiratory capacity is 3,100. Or inspiratory reserve volume, I'm sorry. The average inspiratory reserve volume is 3,100. So we would say that the average person's inspiratory capacity, the maximum amount of air they can pull in, would be 3,600 mils, or 3.6 liters. Okay. Now, so then basically, functional residual capacity, this is basically done by adding expiratory reserve and residual volume. Okay, expiratory reserve and residual volume. And basically, so basically you get the expiratory reserve. That if you're just doing a rough shot estimate, you would add 1,200 to that. You put the two together, and what do you get? So 1,200 plus 1,200 is 2,400. Remember, we said the average expiratory reserve is 1.2 liters. Inspiratory residual, or the residual volume on average, is 1.2 liters as well. And this rate here is vital capacity. Okay, this rate here is vital capacity, and this is a big one. This was actually believed to be the very first ever test ever conducted through spirometry. Now, vital capacity is a big one because, like I said, this is telling you the maximal amount of air that you can essentially bring in and bring out, the maximum amount of air you can essentially utilize for gas exchange, right? And if you wanted to measure somebody's vital capacity, basically, again, you tell them, you always start out by telling the person to take a couple of tidal breaths, just take a couple of normal breaths, and then what would you tell that patient to do if you wanted to get their vital capacity? What do you think you tell them to do? Because remember, what are you adding together? You're essentially adding up. You're basically adding up inspiratory capacity and expiratory reserve, right? You're adding up all the values, that you're adding up all the maximal values of one breathing cycle. So basically, you would tell a person to just inhale as much air as humanly possible, and then without pause, to exhale as much air as possible, all in one shot. So you tell a person to, geez, that'd be pathetic if that was actually my vital capacity, but you get the picture. All right. But that's essentially vital capacity. And then, like I said, when you add all this up, when you add residual volume to the picture, you get TLC, total lung capacity. Now, there are some there are certain disease states that are certainly going to affect this process. For example, when people have restrictive disorders, remember, restrictive disorders are essentially where you see scarring, i.e. fibrosis, of the lungs. And remember, let's think about that for a second. Fibrosis. Basically, what we're saying is scar tissue of the lungs. Now, scar tissue isn't the only thing that makes the lungs really stiff and lose their compliance. It's just one that you hear about a lot. Because pneumonia is so prevalent, especially in the elderly and so on, elderly and children. And now remember a time when you got a cut on your skin, and then you let that blood just sit on your skin, and then that blood, and you eventually, you cleaned out the wound, and then you eventually started to form a scab. That scab is scar tissue, okay? That scab is essentially scar tissue. Now picture that developing in the lungs. Picture a lot of that in the lungs. All right, that scar tissue is really tough. It's basically, for all practical purposes, it's just a bunch of collagen fibers interwoven with each other. All right. It's not the only component of it, but that's mainly what it is. All right. And that collagen is a tough structural protein. It resists tensile or pulling forces, right? So picture a lot of that tissue developing in the lungs. Well, you can do the math here. What do you think is going to happen to a person's inspiratory reserve volume or tidal volume or their inspiratory capacity? That's going to bring it down, right? Because it's going to be a lot harder to inflate those really stiff lungs. Right, or like I said, probably the most extreme example of that would be black lung or coal miner's lung. Where people are, like I said, where a miner's underground and they're breathing in pure coal. Remember, coal is just, if you take carbon and condense it into a solid, that's what coal is, right? And then you build up all that carbon deposit in the lungs. It makes your lungs not like rock hard, but again, really stiff. So as a result, it's going to be very difficult to inflate those really stiff lungs. Now, however, your expiratory reserve and your functional residual capacity isn't really going to be affected all that much by this, because it's actually going to be around normal, or even a little more than normal, because when you breathe that air in, and you stretch those stiff lungs out, those stiff lungs are going to recoil with more force, and you're actually going to bring, like I said, the normal amount of air out. But it's going to be a lot harder to inflate those stiff lungs. Okay. Whereas with obstructive disorders, when a person has obstructive disorders, this is a bit of a different story. All right. Basically, when people have obstructive disorders, like emphysema and so on, this is going to be a little bit of a different scenario. For starters, because when you have these obstructed airways, like with emphysema, because when people get emphysema, basically the bronchioles start to collapse. They build up with mucus. The walls of the alveoli get stiff and collapse, or they have a hard time. They're not very elastic anymore. At least the alveoli that are remaining. So what winds up happening is as the bronchioles and the alveoli as their structure as they start to lose their elastic properties, as the elastic properties start to collapse, what winds up happening is these structures get really stiff and airflow into these gets impeded. Now, that's not just airflow in, that's also airflow out. So that means that the alveoli that remain intact during emphysema wind up retaining air. So what do you think that's going to do to a person's residual volume? The residual volume is going to increase. Their inspiratory volumes might actually go up a little bit just because they've got all this excess air remaining in their lungs. Their lungs are slightly inflated. But these expiratory volumes are going to be greatly affected because of the obstruction of airflow through these bronchioles. For example, you can do a test. It's what's called forced expiratory volume, where when you're doing vital capacity, you tell that person just breathe in and blow out air. And what winds up happening, and basically so if you do what's called FEV1, okay. Basically, that's the volume of air that was forcefully blown out in 1 second. Okay, a person with emphysema, that forced expiratory volume is going to be a lot lower due to the obstructed airways. All right, and the air remaining trapped in their lungs. Okay, so that essentially would be these lung volumes and lung capacities, and basically, remember, the volume of air that we're bringing in and out of our lungs essentially affect ventilation. All right, and basically, we don't use all of the air that we breathe in. Essentially, some of the air is wasted that we breathe in, and that air that is essentially wasted is what we refer to as dead air. Dead air. We call it dead because it does not partake in gas exchange. Okay. Now, if we're saying that air does not partake in the gas exchange process, that is air that remains trapped in the conducting airways. Okay. So what we're really saying with this is that's air that does not reach the alveoli. The respiratory zones, and the areas. Remember, respiration is where gas exchange occurs, right? Diffusion of gases across the membrane. So that's essentially dead. So that's dead air, and basically the areas where that air remains trapped is what we refer to as anatomic dead space. So basically, by definition, that's air that just remains in the conducting airways. Okay, air that does not reach the alveoli. So every time we breathe in, there's always going to be some mixing of air with that dead air because there's always going to be a certain volume of air trapped in our dead space. Now, the average volume of dead space in people is about 150 milliliters. I mean, there's some pretty elaborate testing that you have to do to really get precise measurements on it. So basically, kind of rough shot estimate, we would say that the average person has about 150 milliliters of dead space. Okay, now I'm going to come back to that in a second. Now, physiologic dead space is a little bit different. This essentially is a mismatch in ventilation perfusion coupling. Okay, ventilation perfusion coupling. What this is, basically, what we're saying here with this. Let's say we were to graph. Let's make a graph here real quick, and let's say this was breath rate. This was and we got heart rate here. Right, that's supposed to be proportional. Sorry. Remember, I'm doing this on a cheap tablet here. But basically, what this graph is supposed to show you is that if breath rate goes up, heart rate rises proportionally. Okay, heart rate rises proportionally. Vice versa, heart rate up, breath rate goes up to match it. Okay, so remember that. Because I'm gonna revisit that concept in a second. So basically, there's two ventilation rates that you have to think about. What's called minute ventilation. Minute ventilation is simple. Basically, all we're saying here is how much air are we breathing in per minute. Okay, so let's and this requires just second grade math to figure this out, which is about how good at math I am anyway. So that's why I'm kind of glad that we've got this here. So let's say a person is breathing in. Oh, let's just stick with your regular tidal volume, 500 milliliters of air per breath. Okay, so remember this. Remember the name of this: minute ventilation. Minute. How much air are we pulling in? How much air are we ventilating per minute? How much air are we breathing in and out with every breath per minute? So and let's say this person breathes 13 times, the 13 breaths per minute. Okay, so all you would do is take 500, multiply it by 13, and you would get 6,500 milliliters, or in 1 minute that person breathed in 6.5 liters. Okay, now this is a lot more general. Okay, this is a lot more general because all we're doing is just showing how much air went in and out. That's it. Okay. Now, with alveolar ventilation, this is a little different because you have to remember this isn't factoring in gas exchange. This is just the general amount of air a person's pulling in and bringing out. Okay, so when we're talking about how much, so basically how much air are we actually physiologically using, that's alveolar ventilation rate. And remember that not all the air we breathe in actually reaches the alveoli. Some of it stays trapped in the conducting airways. So when you're thinking about how much air are we actually putting to purpose, you have to factor in anatomic dead space. So basically what this is tidal volume minus, I'm just going to abbreviate this, dead space times breath per minute. Okay, so if a person brings in 500 mils of air per breath, and we say that 150 milliliters of that air is wasted, meaning remaining in the conducting airways, that would mean that only 350 milliliters of air reaches the alveoli for gas exchange and actually partakes in the process of gas exchange. And then again, if this person took 13 breaths per minute, that's going to equal about 4.6 liters or 4,600. I rounded up because it's 4,550. All right. What about 4.6 liters? Okay. That's how much air actually partook in the gas exchange process. Now, let's think it now before I elaborate on this a little more, let's think about this concept of, let's say we're exercising. So basically, only about 70% of the air that we breathe in actually undergoes gas exchange, alveolar ventilation. Now, anatomic dead space doesn't really change. I mean, under normal healthy conditions, that anatomic dead space isn't really going to change. All right. So now let's say you are breathing in. Let's say you're breathing in 2,500 milliliters of air per breath. Okay, so now subtract. So take 2,500, subtract 150. Okay, now 2.4 liters of air, and again I rounded up as 2.35, but now 2.4 liters of air are basically getting into the alveoli, and multiply that by, I don't know, let's say a person's taking 22 breaths per minute. Basically now, that's essentially 52 liters of air per minute. All right, that's undergoing gas exchange. That's a buttload of air, but you get the picture. So basically what I'm saying here is that dead space doesn't change. All right, so the more air you breathe in, the higher percentage of air that's going to reach the alveoli and essentially undergo gas exchange. Now let's revisit this value at rest here for a second. Let's revisit this. Okay, let's revisit that. Now, a person that, now remember the average cardiac output. I mean, the average cardiac output is going to be about 4.5 liters to 5 liters per minute. All right. So now, what do you notice? Ventilation perfusion coupling. That's why it's called coupling, because the two should match one another. Okay, breath rate and blood flow through the lungs and through the pulmonary and systemic circuits should match one another. So basically, as we are accumulating CO2 in our system, and we need to and we're pumping more blood to our lungs to get rid of that CO2, our breath rate's going to have to match that flow. Okay, and vice versa with oxygen demand. So and whenever we disrupt that ventilation perfusion coupling, whenever there's a mismatch in that, that's when we would say the person has an increase in what's called physiologic dead space. Physiologic dead space, which you would see in conditions like emphysema and so on. Because under normal conditions, anatomic and physiologic dead space match. They're both going to be at 150 milliliters. Okay, but now, because like with emphysema, when alveoli fall apart, pulmonary capillaries are damaged during this process, there's going to be a mismatch in the volume of air coming into the lungs, the amount of blood flowing there. Now we disrupted the physiologic ability to undergo gas exchange because we reduced our surface area to undergo gas exchange with. We we decreased our surface area. We decreased the volume of air coming in. I mean, that's going to basically all hinder this process. So that's essentially what physiologic dead space is. Okay, but that essentially is pulmonary ventilation and some basic ideas as to how to measure these and how to use and think about these. The next video, we're going to start talking about partial pressures of gases and how those concentrations and partial pressures of partial pressures of gases change throughout the body.